Andrea Simone. She's a graduate of the University of Windsor way back in 1991. I was almost retired then. Where she obtained an honors degree in nursing. Since that time, she's been employed in Detroit at the Henry Ford Hospital, mainly in the urology field. In 1997, she received her certificate in urology and received the McFarland Award for Excellence and achieved the highest mark on the exam. Ooh la la. In 2010, she was honored for excellence in nursing during Nursing Week at Henry Ford Hospital. She's been a guest lecturer for many organizations, including nursing colleges and universities, the Ambulatory Nurse Council, TIMM Medical, and the VUI Support Group. Perhaps you could let us know what that means afterwards. While working at the Henry Ford Hospital, she was also a clinical nursing instructor for the University of Windsor. She's participated in audiovisual marketing materials for VUI in 2008, 2010, 11, and 12. Her major accomplishment has been the development and successful implementation of the penile rehabilitation program for prostate cancer patients at the Henry Ford Hospital. This has recently branched out into Windsor, Ontario, and other local hospitals. And we're hoping that it will branch out also in the Ottawa area as well. She's married with 2 teenage children who keep her very busy and provide her with a well-balanced life. I'm so pleased to have you here, Andrea. I've just been buzzed ever since that first video I saw of you a year and a half ago, I guess. And I'm so glad to be here today to introduce you and to listen to your presentation.
Thank you, Bill.
Welcome.
Well, I'm honored to be here, and I think that I want to thank Bill. I'd like to thank John Arnold and some other local guys from the prostate cancer support group areas within Ontario that have formulated and put the word out there that I was visiting. So it was a multi-purpose visit, I guess. I attended the conference here this weekend, which was just a wonderful venue and setting. So I went to the Urology Nurses of Canada, I spoke about this actual program that I do habitually in the work setting, and that was taken and received very well. There was actually some local nurses that had a lot of questions about this, so I was able to inspire them maybe to take this program to, the hospitals where they work or the settings to put it in action. Because if you don't have the idea, the concept, and have somebody to be the catalyst to get it there, it won't happen. So I was happy to do that. And then last night, after the first night of the conference, I went to Wasabi in town. Everybody from Ottawa area? Okay, so Wasabi was a sushi place. So I've got a couple nephews. My husband and I took a couple nephews that are just in their first year engineering at Carleton here. So I says, hey, you guys hungry? You're probably sick of campus food. And they were like, oh, they're twins. They look identical. And so we took them out for dinner last night. So that was fun. And the other purpose was to meet you folks and to help you out and to do an actual class presentation. So what I do at Henry Ford, as I lectured the nursing group this afternoon, is in total, Dr. Menon at Henry Ford Hospital, who developed the Da Vinci robotic surgery for prostate cancer and has made that popular worldwide, I was fortunate enough to be in that setting where it was developed. So we saw patients from around the world, and we still do. So in total, I've got over 8,000 men that I've had to work with post-operatively in the post-operative setting, and either their nurse advisor, their counselor, their educator, prescription giver, advice giver, everything. So it was overwhelming in a sense that a lot of questions on my end. I was seeing a lot, maybe 12 to 14 patients a day, 1 week after surgery. And you can imagine going back, I'm presuming, did everybody have surgery for prostate cancer? I'm assuming everybody has prostate cancer. Now, maybe my assumption is wrong, minus the women in the room. But if some people have had radiation therapy but if you've had prostate cancer, you remember the anxiety that you had maybe when you had a catheter in, all of the symptoms that you had, the questions in your mind, the incontinence that you might have experienced afterwards or continue to have, the developing erectile dysfunction that you were disappointed to see was really true, and how that may not have recovered or didn't recover to your full potential. So you go through all of these anxieties. So me as one of the individual nurses in our clinic, working under Dr. Menon on our team, it was my responsibility to make sure that everybody got what they needed and they were happy and they were sending happy surveys in. So my job at some point became a little monotonous because it was redundant. I was saying a lot of redundant things. It was monotonous. It was stressful because I was on a time management, I was seeing a patient every 30 minutes. And to get everything in I had to get in and remove a catheter and do all of this within 30 minutes was a lot. So as I started thinking about the volume that I had to do, I had to think creatively, and I said, well, I'm going to find an education room in the hospital, and I'm going to develop a program and some slides, and we're going to talk about all these issues that you guys have, and I'm going to make a class, and all of my early post-operative patients are going to come. I'm going to make it mandatory that they show up, whether they're sexually active or not, and we're going to start talking about all of these things that you don't really like to talk about anyway. And I did that, and became very popular, and we made a little, it was very comfortable. It was a comfortable setting. I actually invited the Windsor support group to one of my classes at Henry Ford one day, and they were just totally in awe of how well it was run, and the concierge service we had on the side, and the beverages and the snacks. And granted, Dr. Menon started with a whole philanthropy load of money, so we could do that, and maybe not so much anymore, but it's a nice program. So I guess normally over at Henry Ford I would do a formal, it would run about 2 hours. By the time I started and finished with questions, it would run about 2 hours. But I wanted to devote some time to what I think is the most critical for men who are or want to maintain sexual function in their lives, which is pretty much a lot of men, and couples as a patient. I look at it as a couple as the patient. It's not just the man that's treated, but it's the couple, it's the partner, it's the wife, it's the spouse, it's the girlfriend, whatever. So I want to focus today's talk and condense this class just on the erectile dysfunction component. I would like to know, where's Bill? Bill, are we going to do at the end like a Q&A? Or we're going to write down, are there cue cards for, because a lot of people don't like to ask questions personally. So it might be a good idea if anybody has any questions and you feel a little too timid or shy to write down your question because you don't want to divulge things that are personal to you. Just write something down, fold it up, and maybe, Bill, you could put it somewhere in the back for people to put randomly. I don't know. Or if you guys just want to just blare it out, I'll do whatever you want. The downside for me is I don't know you as individuals. So normally when I do a class, usually I know the faces. I specifically know the patients that have had a difficult time kind of going through their process, the recovery. I might have known who had the catheter delayed coming out. I might have an idea of the guy who said he had an erection while the catheter was in. Like, you remember little things of several different circumstances. But I don't know anything about you guys, so it makes it a little bit challenging for me. So don't feel shy, don't feel timid. If I say something in this time frame that we're together that you have questions about and you just want to ask me now, just ask me. Okay, this is informal, okay? So it's just a discussion, okay? So I'm going to skip over all of these slides, and I'm going to, I will tell you this, just for the sake of it. When you are going to have treatment for prostate cancer, the first thing I like to tell patients when I meet them at consult is, okay, our data with Henry Ford is good. There's a lot of urologists that are very good. There's a lot of radiation oncologists that are very good. But the reality is guess what? As optimistic as you are, and as optimistic as you feel, the reality is that expectations of 1 to 2 year period of time that it takes to fully recover. And it doesn't guarantee a full recover in both dimensions of incontinence and erectile function. Would you agree with me? Yeah, it's not a guarantee. Now, most patients can get there with help or with counseling, and that's where I come in. Oh, this is a nice visual that I give in my class. Let me just go back here. I found this slide on one of my apps for urology education, and just shows here's the bladder, here's the prostate, here's the urethra, the main nerves that were potentially saved in your surgery. Right around here, these little guys come off. That's the minor nerves. And this is the prostate, okay? So they take out the main sphincter and they leave this other sphincter in that when you do a Kegel exercise, you feel the squeeze of the, where the apex of the prostate was, and when you do a Kegel, that's the secondary sphincter that takes over for your urinary control. Yes, sir?
What's the blue envelope around those stuff?
You know what, I think it's venous flow. It's a venous flow mechanism. So there's like a dorsal vein that runs usually on the top, okay, part of the penis that gets snipped and cut and so forth. So I think it represents the blood, the returning blood from the penis. But good question. The seminal vesicles are here. So when they take the prostate out, you know, there's duplicate seminal vesicles on both sides. It's attached to the prostate. That's removed as part of the radical surgery along with potential lymph nodes. So what the urologist does is he just cuts at the bladder neck, and here you can see that dorsal vein that was tied off so you don't bleed during surgery. This was severed. They try not to take too much of this muscle out, because if there's a lot of muscle removed, you could potentially be more incontinent than you want to be. But in some cases, if cancer control is important and you had that discussion with your doctor and you know that you had an aggressive surgery or an aggressive cancer, sometimes they can't help that and they have to get into that muscle. And what they do is they reach down, grab the bladder, and they suture it up, unless you had robotic surgery and it's all done robotically like it is at our institute, okay? That's called the anastomosis, if you're wondering the fancy term, and it takes about 6 to 8 weeks to heal in general, and that's what the Foley catheter would look like in general, which a lot of you had Foley catheters, I'm sure. Yes, sir?
Yeah, I thought in a radical prostatectomy, they knocked off all those nerves as well.
It depends on who your surgeon is, when they were trained, their techniques. Robotic guys and in general will try to salvage the nerves because they can visually see it. So there's that visual acuity that the robotic or laparoscopic allows.
Okay, so if it's not done by the robotic surgery, the old-fashioned.
It's the feel technique, and they claim that, yeah, they can feel around and save nerves in the manual technique. I don't have enough experience with open surgery in that way, but I do hear that there's a mechanism that they do to touch around and feel around to save those nerves. So a urologist is the one.
All those nerves are gone. Does your analysis here?
If you don't have any nerves that were saved.
Yeah, the nerve going from brain to penis.
No, there's no. That is complicated when you're talking about actual getting an erection and the nerves. There's different nerves that run throughout the penis, yes, that communicate from the spinal cord down into different plexuses down into the penis. That's very complicated. But nerves specifically around the prostate gland is what we're referring to. So if those nerves are taken, then they're not going to regenerate, but they're gone. Okay, but there's concept that Dr. Menon developed, the veil of Aphrodite. You might have heard that if they do robotic surgery here, which I believe they do, if they refer to the nerve sparing techniques, even though they're spared, men, actually all the men that we operate on, most of them will be impotent for a period of time anyway, because the nerves are in a state of shock and it takes them some time to regain function. So the time frame that they regain their function can be anywhere from a couple weeks, which is rare, very, very rare, even 4 or 6 months, which is even still rare. It's closer to a year to 18 months. I tell patients you can expect your function to return in about 18 months.
Well, what if they cut out those nerves?
Then there's options to do something permanently. You'll probably, if you're sexually active, if they cut those nerves out, there's a vacuum pump, there's the medications, and there's also prosthesis that you can consider.
They do robotic surgery here at the General,
Okay.
but others have an open surgery. I had open surgery, traditional, but they don't automatically remove the erectile, the nerves we're talking about. It depends on what the state of the cancer is.
Correct.
Right?
Typically, yes, and,
So in my case, it was clear they had to remove,
yeah.
on one side, not on the other.
Correct, and, the same thing, a relative of mine that lives in Ontario had a radical laparoscopic prostatectomy, and he had a nerve-sparing procedure as well. He had it done in London, and, he was able to, but that was different. Yours is open, so it's more of a touch and feel kind of situation in a confined space. So, do you guys like my cartoon? It took her forever to find it, but, he popped up. Urology, you just love the field. There's a lot of little jokes out there. We do have a sense of humor. If I say something, I don't mean to offend you, but we, as nurses, we do have a sense of humor, as well as urologists in general. So.
How many nodes are there around the prostate? And do
gee,
they have names, and what are the names?
You know what? They haven't gotten to that point where they can name them, and it's still a concept, okay? They are still trying to divulge now where exactly the sexual function originates within that area, whether it's the top part of the prostate, the back part, the side part. We feel it's the back of what you call the posterior and the sides. We're now experimenting with a different type of surgical technique. It's the same robotic surgery, but just done in a different manner to preserve nerves in the front, but where the prostate's removed at the back near the bladder underneath, robotically. Rather, it used to be done over the bladder in the front. So it's a diverse field, different opinions. Urologists might argue about this nerve thing. If you ever go to a urology conference and there's a urologist present, they'll argue about some of this stuff in general. But it's not a defined space or visual area that some urologists say doesn't even exist. But in our urologist perspective, it does. But anyway. I tell my patients that, one of the common questions is, once I've had surgery, when can we start divulging into sexual function and sexual activity? Well, number one, that's on the advice of your urologist, because some urologists practice a little differently than others. We will tell our patients that they can comfortably begin sexual activity within 2-3 weeks after surgery. And usually we get our catheters out at 1 week. Patients don't have Foley catheters at our institution. Since 2007, we started using suprapubic catheters. So those are catheters. They're actually punctured during surgery that go through your abdominal wall just over the pubic bone, and it's a little tube that drains to a bag. Because one of the patients mentioned to Dr. Menon, said, "This is a wonderful operation you created and invented, but if you could do it any other way, because this penile catheter is a bugger, please do." So he looked at me and he says, "Andrea, let's do suprapubic catheters." And I looked at him and I said, "Are you crazy?" So for reasons in my mind, thinking that urologists and nurses thought you had to have something to go through those stitches to protect them so they would heal and conform, we found the opposite was true. It made patients more comfortable. There was less bleeding, less bladder spasms. It got the catheter out sooner. It was excellent, and I just love it. I also love it because it has its own little valve on it. So after the patient's been discharged from the hospital on the 5th day after surgery, we tell them to clamp the valve off and start experimenting with their own plumbing just to see what happens. And we give them a little chart, start measuring how much you're able to urinate, and then open the valve, check what's left over. They come back to see me 2 days later, which is post-op day number 7. I sit down with them and look at their chart and go, "Well, I think you're ready to have this removed. You're doing well, you're not." Sometimes I might move them to get an x-ray, or if I have to, I might confide with Dr. Menon, who might be in surgery or whatnot. But it's a really good way to do it. You take the catheter out, it heals up that hole within 24 hours. You just put some gauze on it, and it's nothing. So men are a lot more comfortable. So, but anyway, intimacy, 2-3 weeks. Your level of desire shouldn't really change unless you've been treated or you've had a problem with decreasing testosterone levels over a period of time. Some men come to us and they've been on testosterone therapies, and we take them off the testosterone therapies. But if you had a problem with desire and you were being treated for it, you're probably going to have the same level of desire after the prostate's removed, and this is all finished. But now, what's changed, and I'm sure that if you were to mention it in Ottawa, hormonal therapy like testosterone is typically something that would be contraindicated in somebody who has prostate cancer. But our thinking is a little different based on recent research. A specialist out at Men's Boston Hospital, Men's Clinic, Dr. Morgenthaler, counsels his patients post-prostatectomy or post-treatment for prostate cancer with testosterone if they are symptomatic and if their blood levels indicate that it's low. But otherwise, if you went through surgery and you had a good drive and that wasn't an issue, it should remain the same. Now, the only problem is when you experiment, whether you masturbate or you start to hug and cuddle your spouse or your partner and nothing's happening, that's because of the nerve injury, okay, due to the prostate coming out, or the lack of nerves if there's no nerves. So with excitement, you'll still have orgasmic activity. You might have a little leakage of fluid that comes out of the penis. It's usually a little, sometimes urine with orgasm. You might get some urine that escapes, or even a little bit of mucus from the urethral glands that will be secreted, but it is not semen. A lot of men will ask me, can I impregnate somebody with this white stuff? I thought you told me that nothing could come out of there. That white stuff, that's just regular mucus, and it's not semen. You don't have to worry about that. But there's no true ejaculate. But you may get a partial erection with sexual excitement at this early surgery, but early post-op period, but usually not. Usually what you would need is some therapies for that. So why, have you guys heard the term penile rehabilitation?
Yeah.
Okay. Has anybody who's been treated for prostate cancer had a program of some kind of penile rehabilitation? Okay,
There's a
all right.
doctor in Ottawa who specializes.
There's a what?
A doctor in Ottawa.
That specializes in penile rehab?
Dr. Bella.
Oh, he specializes in it. Okay, but that's just regular erectile dysfunction.
Oh.
Does he do anything proactively? So if you're treated for prostate cancer, is there a program where you see Dr. Bella right away and
No.
you get pumps and injections and all that? Okay.
Not in my experience.
Okay.
But he
In fact,
does
you have
teach
to fight
about
the
that,
fear.
and he
Takes
does tell you about
7
it.
months to say it.
Okay, so
Yeah,
right
a lot of
around, my
doctors don't
advice is, once you get a biopsy or you're testing for PSAs, maybe you should make your appointment ahead of time. so
He
you can-
does, in fact, see you before you go in for your surgery. If you're going for a radical prostatectomy, he talks about all the tools that you have.
Good,
And
good.
I've been in a couple of his meetings. And,
Oh, good, so he has a meeting specific for patients.
No, it was for the foundation, and we were invited. So we
Oh, so it's
talked
not
about
routine
the
meetings?
advanced, no.
In fact, depending on your urologist, you may have to fight to get a referral to him.
Yeah. I
He's
know.
very busy.
Yeah, I know. A lot of, whether Canada or United States, they're all facing the same thing.
But he does do the implants.
Yeah, that's good. Yeah, because the implant, after what I talk about today, if sexual function is still a problem and you've not been successful with therapies that I'm going to discuss, an implant is usually a viable option for patients. So penis atrophy, the whole concept of penile rehabilitation started around the late 90s where they did experiments, I think it was on rats, and they found that if you cut these nerves around the prostate, the penis, the muscle in the penis fibroses, it shrinks and it atrophies. And the reason is because the nerves have been traumatized. So if we don't get oxygenated blood into these areas that fill with blood, typically, then the penis will die. Not so much, but the insides of the tissues will shrink. You can see the urethra is down here, and the expanding bodies for an erection are right there in the penis. And you can see that the trapping mechanism would be all these veins. So with, this is a normal erection, you get the blood flow that comes through the main artery right here, and then it fills the cavernosal tissues with blood, and then as it expands, it traps the venous system, and it stops the blood flow from returning to your systemic circulation. So anyway, the thinking is the rehabilitation is going to combine a couple of things. So you can support the penile tissues, because with the nerves that have been paralyzed, men are not getting what they normally get. And do you guys know how many erections you normally would get during the night before you had prostate cancer surgery? Do you know
2 or
what's
3 dozen.
2 or 3 dozen? Okay, that's wishful thinking.
A lot of dreaming.
Okay, a lot of dreaming. I guess it depends who you are and what you're dreaming about. So the 3 to 5 erections per night are pretty much average for men while they sleep. And for the women in the room, you might not have heard this, but men usually wake up with pea hard-ons, they call them, you
Yes.
know, and that is an indication that everything is intact and it's functioning just fine. So after a prostatectomy, you'll wake up and nothing's there, and that's how men will know that, you know, they need some therapy, because the nocturnal erections, these 3 to 5 erections that you get during the night, is helping making this tissue healthy. That's nature's way to keep that tissue healthy. So now it's not getting its rehab, it's nightly rehab. Now we have to force upon it a little bit of rehab.
So what do you do to keep that energy up in those blood vessels, to strengthen them?
Penile rehab, we're going to talk about it. And how we're going to do that is by discussing the products that are available to assist that. And it's all based on research. This wasn't something that Henry Ford just came up with and said, hey, let's just do this. There's been research. Now, research hasn't been perfect, and we've not been able to show what the best therapies are, the best combinations of things, but we have a good idea. But it's almost patient-specific. You have to, it's a trial and error process that I tell patients in my class. But what you could consider using would be oral medications such as Cialis, Viagra, Staxin here in Canada. We have Staxin, we have Stendra, there's Levitra. You can use a vacuum pump, which we'll talk about. Muse, which is a medication pellet that's inserted, and penile injections. And some of you, if not all of you, might have had some experience with one, if not all of these things. So we'll have a lot to talk about. So yes.
Before you get on to all these drugs, can you go back to the atrophy question?
Uh-huh.
Is that a very well known? Because I mean, my urologist never mentioned it for over a year and a half.
Did you notice that after did you have treatment for prostate cancer?
I was operated.
So did you notice that you were a little shorter?
Hell of a lot short, couldn't find it half the time.
Yeah.
I thought I was going to be having my female taken.
So that is atrophy.
But how come the doctors don't seem to know about it in Ottawa?
Well,
Things that I read, so anyway.
they know about it.
Why don't they say something?
Maybe they wait for you to mention it.
They wait for you to, well, you know what, I don't want to speak for them, and they're integral in what they do, but, you know, it's known, because they attend conferences, they know that all of this exists. They have to prioritize, just like the rest of us in the professional world, and they only have so many resources, and they can only do so much. And they only have so much time for you as a patient to spend in the office, because they have a whole clinic load of people. So, from that perspective, now, that's why I'm here. I'm here to try to inspire you guys to bring it there.
Okay, but as a medical issue, is it a significant medical
No,
issue?
no, not at all. If you think of a person that was in a car accident, or they had injured a hip or a leg or an arm, there is rehabilitation for that, because if you've, you know, had some neurological damage and you lose function and motor strength because of nerve damage, they may put you through physical rehab, right, to strengthen your bicep or whatever you're trying to strengthen. Because if you don't, have you ever seen somebody that's not equal in their body, and they might have been inflicted from some neurological issue and they're asymmetrical because maybe the physical therapy wasn't effective or they didn't have it? Urology thinking is advanced in the States. It's not quite as advanced here. So what I'm teaching you right now is a lot of it has come from the States, but a lot of this actually came from Europe. The first people to do these studies was Dr. Montorsi from Milan, and that group where they did penile injections and that. Canada always seems to be the last to kind of do this, but this has been a concept for a while now. But a lot of it is multifactorial reasons why it's not here. But you know what, my goal, and I know Bill's goal and John's goal, and some of the nurses that might be here in the room, maybe their goal is to get something going here in Ottawa. Because wouldn't it be nice to have this Canada-wide, worldwide? Because I'm very passionate about it, because I know the quality of life factors that exist, and I know the reality. And I think, again, I have a high respect for our surgeons and our doctors. But, you know, if you're going to treat the cancer, which is very important, and I understand that, but you got to have a backup plan to deal with issues that are very important to people, and quality of life issues. And that's what this boils down to. At the end of the day, it's all quality of life, right? So, but you've got great questions in that, and you know, maybe I could better answer them later after the lecture. But
the other one I was mentioning is when I talked about physical therapy to strengthen those muscles as opposed to chemical drugs. Is there any exercise or muscles?
no, No, there's no
Or
physical
masturbation
therapy.
or something? to-
Masturbation is not been researched to my knowledge, and that often comes up as a question in my class. Can masturbation actually take the place of the vacuum pump and help maybe? And potentially yes, because you are getting some systemic blood flow in as you are masturbating. So we really don't know, but I always tell patients, go for it. You know,
You want to encourage the
whatever.
blood flow,
I've
that's the
had-
point.
Yes, I've had patients ask me, well, instead of the vacuum pump, what if she, oral sex? I'm like, oh gosh, you guys think of everything, So anyway, I says, anything can be considered your therapy. It's what you define it as. And the whole object is getting blood flow in there. So I'm gonna have to keep rolling because we'll run out of time quickly, okay? So the oral medications, I'm not gonna spend a lot of time in this because all you guys, if you are having erectile dysfunction and you've not been tried on an oral medication, you should go to your doctor and get one, unless it's contraindicated and you're on nitrates, then you can't take these drugs. There's different drugs, there's different dosages, there's different ways that they work. I say research it because a lot of them are timed. So if you take a Cialis, usually you gotta wait 2 hours before you try the Cialis. Viagra, you gotta wait an hour before you try the Viagra, but you have to take it on an empty stomach. And the urologist would want to know that if you failed it, you've tried on 3 different attempts. So there's several stipulations on these medications. And not any one is superior over the other. I will tell you that out of all of them, they're all equal in my mind, because I've had patients that are effective on several different kinds. Because if I have a side effect on one patient, was a headache, we'll say, well, let's try on this one and we'll see how you do. Or we could try reducing your dose, maybe you'll take it a little bit more often or less often. So we titrate it or move it around according to how the patient responds to it or what kind of effect they have. So timing and foreplay is very, very important. You have to know which drug you're taking and when it's going to best work for you. Cialis has a lot of back pain sometimes. I don't remember the actual percentages, but it's known as the myalgias. So any kind of muscle, back, butt, leg pain, if you're on Cialis, sometimes patients will develop that. If you take a different one instead, it won't have that side effect. There's different ways to take the drug. There's low dose Cialis, taking it every day. There's high dose, taking it a little less often. And like I said, research isn't perfect. We don't know what the exact fit is. And what we tell our patients is whatever you can afford, take whatever your plan, and I understand plans and affordability here and all that. Our insurance coverage is not that great, as it is in the States. I understand the issue there. But don't expect an erection too early. So if you're taking it for rehabilitation, we have patients take it just to help oxygenate the nerves. Because for nerve-sparing patients only. They take it just to felt at night to oxygenate the nerves, help those nocturnal erections along. Alternatively, we tell patients that they can take the medication prior to sexual activity. Okay, if they want to dive into that and see how that's working just with the oral medication. We always tell our patients to try. They may be very satisfied with what the drug does to them after surgery in some time frame. It's expected to work at some point. We just don't know what time interval yet. But we just tell them that they can start taking 50 or 100 milligrams a dose on occasion. Sometimes they'll take it, they'll try to take 100 milligram of Viagra, and none of these tablets are scored, so they'll try to get a pill cutter and cut them in 4, and they kind of crumble because they're not exact dosing. So there's different ways to get around this, different ways to use it and get creative with it. The vacuum erection device, has anyone, well, I guess what I'll say is for sexual function, I don't know if anybody's used it for sexual function, but the feedback that patients have told me, that gets in the way of sexual function, it gets in the way of mood, it gets in the way of when I want to be romantic. There's got to be something better, and that's where I emphasize the penile injections. But for the use of the vacuum pump, for a patient who's rehabilitating, I tell them, I know you don't want to use it for sexual function and performance, but use it for penile stretching. And in my lecture today, I says, well, when I'm teaching a class, I'll call it their penis Pilates. Just grab your vacuum pump, and we're going to call it penis Pilates. You're going to get the blood flow in there, release it, get it in there, and you do a 5-minute, 10-minute exercise, and you're done. You might do it once a day. I've got some patients that really are wanting to maintain their penile length, and they're pumping twice a day. One guy called me and he says, Andrea, it's grown. And I said, no, I don't believe it. He was a lawyer too, from Texas or somewhere. He said, no. I know. I said,
Did
no.
you keep talking to him?
No, I says, no. Yeah, I had one guy that called me and said, he says, he says, I'm using my vacuum. I says, what do you mean? I says, the vacuum you were prescribed? No, the vacuum cleaner. Honestly, I'm not lying. This was a farmer from one of the states, and he was your typical farmer, and he had a wife, and he was so serious. He says, yeah. He says, honey, what was the name of that vacuum again? Wasn't that a Hoover? Because I said, well, I bet it was a Hoover. I was just joking with him, not knowing he was serious. So he's having a conversation with his wife. The wife says, yeah, it was a Hoover. And I went, oh my God. I said, don't do that. No. So he says, well, it works great, but the only problem is it just takes everything out of my bladder. Oh my gosh. So I said, please, it's just like buying vacuum pumps at those sex shops. And I don't know about Ottawa. I know you're close to Quebec, and I know how risque Quebec is, with the sexual function in the stores and that. But Windsor is too. You got a lot of those stores that exist. The vacuum pumps that are sold in those places typically, some of them can be dangerous, and I don't promote them because FDA-approved models are the only ones that you should use because they have pressure release valves on them, so you can't suction too hard. So vacuum cleaner obviously is not wise. Okay? And I can't even start to tell you what kind of damage you could probably get into. So the vacuum erection device, it could be used every day. It's FDA approved to use as often as you want. It could be used as needed for sex along with the tension rings. Now, to enhance the experience, if you wanted to use it with sexual function, you would combine it with one of the oral medications because you've got oral medications that are affecting the nerves to help with nerve flow, get a little bit of blood flow that's chemically working. And then you've got a mechanical device that's also as a double up, right? So you're combining your therapy. If you're using it for sexual function, once you get a good response, you are then going to have to use a tension ring, what I call a cock ring. There's a picture of it down here in the slide. And if anyone has seen the vacuum pump, you will see what it looks like. Do you guys need to see the video on the vacuum pump, if I could get the video up and running? Or does everybody know the concept of the vacuum, or have you ever heard of it? Who wants to see the instructional video? Anybody? Or do you want to skip right to the meat and potatoes and good stuff? It's up to you. Oh, okay. Okay. So the vacuum kind of bores you guys, am I right? Yeah? Skip. Okay, so fitting, Robin Williams, loved him dearly. I loved the movie Mrs. Doubtfire, beautiful. And see, the problem is that God gives men a brain and a penis and only enough blood to run one at a time. And I can't tell you how true that statement is because, I see patients on occasion that absolutely won't work with us out of fear. So when we tell them, honestly, we really advise you to do this treatment or that, and usually what I'm trying to impress upon them is, let's do these injections. And they're like, no, they're already sweating thinking about it, and so they leave. But, 2 years later, we'll see that same patient on our doorstep. He's in our office. I take him into the exam room, and I say, at this point, you're frustrated. Let's do this injection. It's not going to be as bad as you think, and you're embarrassed. You guys start sweating. I've seen it all. I've done this thousands and thousands and thousands of times. It's not painful for me, but the reaction that you guys exhibit is like, okay, and it's like you look at me and I give you instructions. Okay, just drop your pants and then sit on the table. You still look at me with like this blank stare because you're so nervous. You can't even process thought or anything. So I'm like, drop the pants, Okay, sit on the table. Here's the sheet, and then we'll give them the injection. And after the injection, wow, I don't know why I waited so long. That was nothing. And I said, I'm glad you feel that way because now you can get your quality of life back. This is the instruction. This is what you're going to do, and so forth. So that's why we do things a little aggressively at Henry Ford. And what I mean by that is we get them on injections. As soon as I take their catheter out, we give them a penile injection. I don't tell them that at that time. I don't sneak that in later. Because if I tell them too much too soon, their anxiety level's way up here. So I have a printout at the back that Bill might have given you. It's an orange printout, pumping technique. So if ever if there's anybody in the room that has had treatment in the past 2 years, it's felt that penile rehabilitation with the pump is probably a good idea. And I have a printout of this, how to pump and so forth. The codes and the kinds of pumps, that's already a handout too. The different codes for the classic. There's the classic, which I think is the prescription one, and then there's the, I can't remember what it's called, it's the cheaper one without the prescription. Both are FDA approved. Tim Medical, you may find the pump here in Ottawa still under the name of Tim Medical, and it's the Osbon Erectile. It's Osbon Erectile is the name of the actual pump, but the company that bought Tim Medical is called Auxilium. And this is one of the pumps that we support at Henry Ford because we find it's the best quality. And if you're getting an FDA-approved pump, as we recommend, quality is going to be important because it's a tool that you'll be using for at least 2 years for your rehab period. If you're under the 2-year period, it's good for you. If you're at 18 months, I don't know, I might just would recommend that you go to something that's going to be effective for sexual function. Because there'll be a point where we move you from rehab, because it wasn't that successful, to actual treatment for just erectile dysfunction and work with what we got to work with. Because not everybody will be successful even though you're rehabilitating. And that's because it's a very complex area. We cannot guarantee, just because we saved all your nerves, that your erections are going to come back or be as normal as they were. We can help and we can assist and we can do what research tells us to do, but there's no guarantee. There's no guarantee with anything. You can have surgery and you're not going to have that guaranteed outcome that you want. So there's no guarantees. So Auxilium is the one that makes this pump. So any of those health supply stores or whatever, home product supply stores, you could ask them for it. But the over-the-counter one, you can get it without a prescription. It shouldn't be more than $175, I believe. You can even get it on eBay, I think, or Amazon. Okay, so the classic model shouldn't be more than $175. So has anybody heard of Muse? Muse? No, okay. Muse is a medication.
That's a suppository?
Yes.
Yeah.
Okay, so some of you may have been familiar with Muse, and I want to give a quick demo of how it works. And if you want to pass around these brochures, or did you guys already get one? Just one per couple if you could, okay? Thank you. And also, if you could pass around, I want you guys to take one per couple. This is a sample, but it's a placebo. You can't really use it, okay? So don't think that you're going to get, a good effect from putting this in. All it is plastic, and who knows what's in here. So don't put this anywhere it shouldn't go, okay? I just want to demo it. So take one per couple, because we're going to do this together. Don't open this up yet. And this is where your listening skills are going to really come into effect. Because sometimes I'm sitting here, and I got this curious guy opening it up, taking it apart, and going, you didn't listen to instructions. It's not for use in humans, so this is just a demo. Okay, and anybody who's here, nurses or anybody, take one. We'll work at it together. I'll show you guys how it should be used. But basically, the medication, it's known as Prostate, and it's a potent vasodilator. It's in, I don't know if you've heard about the injectables, the Trimix injectables. Prostate is a component of some mixes, penile injections, which we usually don't use. But Prostate can cause pain, penile pain, aching, throbbing, and for those of you that might have had experience with the suppository, you may have had some of that as a side effect. For rehabilitation, we always tell patients to try low doses. Low doses are 125 to 250 micrograms, and that gets a good amount of blood flow up to 72 hours. So you're oxygenating that penile muscle, because what happens is as it's inserted into the penis, which I'll demo, because I'm going to need a volunteer. Yeah, I know, I'm pointing to you. Yeah. Once you insert that pellet gets absorbed through the walls of the urethra, penetrates, and it vasodilates. It opens up the arterioles, and then blood flow from your circulation just ends up coming into the penis. It's contraindicated with anybody that has myelodysplastic disorders, bone marrow problems, clotting disorders, sickle cell disease, things like that. And there are higher doses, 500 or 1,000 micrograms, that can be used for sexual function. But in the patients that have been newly treated for prostate cancer, I usually don't go up to that dose right away because of the side effect of pain. Patients may not tolerate it because of the aching, the pain, and it might work well, but it was just too intolerable, okay? Did you have a question?
I just wanted to ask, is this like an alternative to injection?
Yes, this is something that would be another treatment and an alternative to the injection, so it's something to think about. They come in boxes of 6, and I'm sorry, I had a travel bag. I flew in from Windsor, so I had to fit on my luggage with Porter, this bag that was this big. Had to include everything I wanted to live in for 2 days, and my teaching bag took up 3/4 of that space. So I had a couple layers of clothing, but I didn't bring the actual Muse box, but the Muse box has 6 suppositories in it, and you could either get 125, 250, 500 or 1,000. So the higher you go up in the micrograms, the more potent effect, and potentially, of course, worse side effects. So, you know, some patients can get a dropping of blood pressure with it, especially at higher doses. So patients are told, you know, don't drive a car or do anything that requires alertness for an hour after you've taken it, just in case you get a little lightheaded or you feel like you're going to pass out, because your blood pressure, you can get an effect from that. And you cannot use this, if you're also using penile injections, you can't use this on the same given day. So you have to do these, you know, you might want to use a vacuum pump one day, Muse another day, injections another day. You may not want to do any of that and just do injections, you know, but we'll get into the injections. Yes?
How quickly is it absorbed?
It works within 5 to 20 minutes.
Oh, okay.
If not
So
faster.
then you
It's
feel
going
it.
in through the urethra, so it's a longer absorption time. It doesn't work as quickly as the penile injections, because the penile injections are going right into that space. Boom, usually within 5 minutes
So
it starts to
when
take
you
effect.
put it in, and there's irritated pee, and then, you know, such and that.
Yeah, I'm going to demo it and I'll show you, but yeah, yeah, there's some things to think about in administration, so. I don't favor it.
These lower doses don't give you an erection.
They could. And some men might want to combine the low-dose Muse with a vacuum pump. I have some guys that combine the vacuum pump. They might use the vacuum pump because a lot of guys will say, my penis shortened so much it's almost buried. So I see men that are really concerned they can't, you know, or they have a bigger belly, they can't see it. It's hard for them to manipulate all this stuff. And this is where the partner really comes in handy, because this is kind of interesting when you're trying to do all this together. It's teamwork. It really is. It's a teamwork thing. So the vacuum pump would be used to try to extract the phallus, and then you could get the pellet in, okay? And then you could, you know, wait for the Muse to work. Then you'd have to put on your constriction band. But for, you know, you can use what I call a cock ring or a constriction band, but you have to wait until the medication takes effect before you close off all the blood flow from your circulation, because medication could still be working. So you want to make sure that the medication is fully worked before you put the band on. So let's demonstrate. This is where you guys are going to be kind of intimidated with this length, I'm sure. But I had to make sure I had a good visual, okay? So I had to have a good visual. It was the pump rep that actually brought me in this one
I
day.
thought that was normal.
That was small.
That's a fallacy, I have to tell you, you know. Wouldn't you ladies agree? Yeah. No, that's a fallacy. But anyway, I like this model because it's got the veins, you can see, you know, it's good for the injection teaching and everything. So what you would do, I'm going to put my little buddy down right there. You would wash your hands, you got your little package. Now are you guys ready to open it up?
Yeah.
Okay, open it up, just don't do anything to it, just let it fall in your hand. Don't take anything apart. I know there's some engineers probably in the room, there usually are, and they're like taking things apart, trying to figure it out. We're going to do this together. Okay.
Does this whole thing go in the end?
No. No, I know. Palpitations, I know. Relax, guys, relax, relax. I've actually taught men in the clinic how to use it and have them do it, and they, same thing, they're looking at you like, what the heck? The most important thing is that you urinate first before administration. So you urinate, you have to empty your bladder, and it also helps lubricate the tip of the meatus, so it allows a few drops of urine to act as its lubricant, right? So then what you want to do, if everybody holds it up in the air so the body of it is pointing up. Everybody just show me that you see what you're talking about, because you have to do it right. It's pointing up. Okay, you have your thumb and forefinger on this round thing, right? Okay, so take your other hand, and we're going to take that lid off. Okay? Are we all on the same page?
Yeah.
Okay, and that, let me see, did you do the same thing? Okay, it's hard for me to see back there. All right, so when you're standing up or sitting down, wherever you want to do, you take the penis, you stretch it out, and you just pinch the urethra, the opening, keyhole. You then would take this, tip it inside. It's going to be inserted up to that hub. See that hub where it gets thicker? Okay, you think it looks really bad. I don't know if I can do this, but you know, it's not that bad. If it's lubricated, you can even put additional lubricants or Lube or whatever you have, Astroglide, whatever you want could go in there. You then tip it in, and it's going to go in very gently like this. And then it has a little button on the end. So what I want you guys to do is I want you to push the button, and it's going to pop out. It pops out real quick. You might even miss it. It'll pop out in your hand. Did you see it?
Am I missing a part here?
Oh, you weren't listening.
I have to press this, I guess.
No. I can't. Do you want to bring it here for me?
Nothing popped out of the hand, it's just a little tip.
It's a little tip.
There's something that's still inside.
Yeah. So you couldn't see me, obviously. So what you would do is you would take that off.
Okay.
Yeah, and then you push it. See that? That was my tip. And that's what that is. Okay. So if you want another one, there's probably another sample floating around. Okay. So what happens is you push that button. Once you push the button in, you then leave it for a few seconds and you just move it back and forth just a little bit to help dislodge it. It's inside, right? And then you pinch the penis, pull it out, and always look to see, make sure it didn't follow the applicator, because sometimes you can push it back in. The most important thing is once you've inserted it, you have to massage the whole glands, okay, the whole penis, for about 30 seconds to help absorb it. If it sits in one spot, it might burn the urethra a little bit or get that irritative symptoms. So you want to avoid that by just moving that back and forth. Then you wash your hands, put your stuff back, and stand up. It's going to work better if you're standing. So if you go down and you lie down, say, honey, I'm ready, you know, and you know, do your foreplay thing and that, it's not going to work as well as if you're standing up. Allow it to work first. And once it's worked, you may need to consider a little constriction device. Now those sex shops, you know, if you've never been in one, you need to go in one. I mean, if you can, because they've got nice, comfortable rings. There are a lot of rings that come with the vacuum pumps, different sizes and that actually are made to work with the pump. But if you just need a ring to support blood flow because you cannot maintain an erection, if that's the problem, or get your neighbor or a friend or somebody, just say, can you go find out what kind of rings are in those shops? Because those are the ones that you will have to experiment with. There's silicone, there's different varieties, different comfortable rings. So you just kind of have to experiment around with it. Yes?
Is the idea that you're leaving a 1 millimeter circumference thing inside the penis?
You're leaving the applicator in, and it goes right to this, to where it gets
Yeah.
wide.
Then you push the button?
Yes, then you push it.
What does that do?
That ejects the medication. So you missed
So
it.
maybe a millimeter circumference of medication type thing?
No, you didn't, but did you push it? Did you, because,
There was a little thing that could rub off.
and that was the medication. And
Okay.
that, so this is an example of what it would look like. And, you know, it gets, yeah, so that's it. And I've had some patients, if they're not careful, it'll pop out on the floor, or leak out, or whatnot. So the bad news is it's extremely expensive medication, and your insurances probably don't cover it. You know, I think it just depends on your plan. Okay, so these are questions, things that you might have in your mind. You'd have to look into it with your urologist or your plan. Because again, I don't have a lot of experience in the Canadian system. I deal with the American system, and that's another beast. So, okay.
So the little tablet that fell out is this
That was it.
simulation of the...
That is an actual placebo of
Yeah,
this.
it's just a drop.
And that's exactly what it would look like in its medicine form. Yes?
I just want to mention to everyone that here in Ottawa, there's an excellent sex shop. It's called Venus Envy, and the staff are extremely professional and very helpful, and they even have education sessions.
Oh,
And
nice.
it's here in Ottawa. It's Venus Envy.
Venus ending. So
Envy,
Venus.
Envy.
Oh, I thought the goddess Venus. Okay. Envied.
Envy, just envy.
Envy.
Venus
Play on
Envy.
words on penis envy.
Oh, okay. Envy. Okay. We have. We've got one in Windsor. It's huge. I forget the name of it. Anyway, but every city usually has one, some more than others, but thank you for mentioning that. Marion is a urology nurse here in Ottawa, so if you have any, correct, in this region, correct, Marion? Marion, right? Okay, so if you have any specific questions to what's available here, she may be the resource person to ask questions, because I really wouldn't know. Yes?
How old is this third?
Oh, Muse has been around for, long time. Yeah, it's been around. It's known as Muse or Prostadil. It's the same ingredient that would go in a little vial of your injectable. Yeah. So, we're going to move on to the injection. So that's another option for you guys. Then we've got the penile injections. We push this on our patients just because it's effective. It's the best to offer satisfying intercourse. Works within 5 minutes, maybe up to 15 minutes. It works just like Muse. It's a medication, but it goes right through the walls of the penis on the outside of the shaft. It's safe, it's usually painless with the correct technique and, practice. It takes a lot of practice. And when I teach our patients, I tell our patients to get a little grape and take a needle and practice on the dexterity and manipulation of the syringe and that before you actually put it in the penis yourself. Because usually your first dose and the teaching is in the clinic with the nurse or the doctor, right? So before you are apprehensive doing it on your own, just a grape or something that has a thin skin that mimics that. Side effects: penile pain, bruising, curvature, infection. Prolonged erection is the most serious. If you get an erection that won't go down after an hour and a half, you should be calling your nurse or doctor to find out what changes you should make. And definitely, if it's a 3-hour erection, you should go to an emergency room and not ignore that, because you don't have any fresh blood that's going in and circulating within the system. You may combine it with orals, vacuum, and the ring if needed. You cannot use the Muse and the penile injections at the same time on the same day. Okay? And adjust the dose in units. We use the insulin needles. So I can pass one of these around. You can take the lid off. Be careful when you pass it to your neighbor. If you want to, I'll just pass the syringe around just to look at the size of the needle. This is the only size you need when you do an injection. And the dosages are in units because it's a diabetic needle. It's meant for diabetics. So that's what we use. We draw up our medication. This comes in it's a compound. I don't know if anybody's gotten any compound meds from compound pharmacies. This is something that's, it's really old, it's turned yellow now, but this is an example of what your pharmacist would give you. You keep a vial of it in the fridge, take out what you need, dose according to what your doctor has you on, put it back in the fridge, and it's good for 3 months, sometimes up to 6 months, depending on what the formula is. I tell my patients in our class that we have in our Detroit area different love potions. So potion number 1 all the way up to potion 15. Bimix, different strengths of 2 ingredients, and then there's 3 ingredients known as trimix. So there's some mixes that can cause more pain than others. This is where your coaching from your nurse or your doctor would be helpful. So I'm going to demonstrate how this is done, and hopefully will convince you guys to potentially try this sometime in your future. And you won't be too scared. So, technique is everything. We always start with a 10-unit test dose in our office. So I draw up the medication, and when you're looking at your anatomy, I should put the anatomy slide on here. So you are trying to aim at an area that is at the side of the penis. So 10 o'clock, if this was the circumference of a clock, 10 o'clock or 2 o'clock. You don't want to go on top of the penis, because there's nerves, blood vessels, okay? And you'd want to stay away from the underneath part where the urinary channel is, where you put the Muse in. Yes?
Anywhere along the length?
I'm sorry?
Anywhere along the length?
From the base to mid-shaft. You don't want to go too far down, okay? You want to avoid veins, because you don't want any bruising, and you don't want to get any scarring inside, because then scarring can happen, and then you notice your penis starts to curve a little bit. So, you don't want to do that. I just did I looked at our results of all the patients that returned in their follow-up at 4 months in our office, and 89% of the patients at 4 months after their robotic surgery were sexually active on the injections. They were happy campers. 11% of the patients They failed it just because of a lot of anxiety. One guy had performance failure issues. One guy found it extremely painful. Okay, so, but majority of men, this is a viable, good technique. And it could be used permanently. It could be something for your lifetime. Yes?
That's like a one-shot deal. Like you do it each time you want, you don't do it once.
This is something that you would do a shot right before planned intercourse.
Right.
No more than 3 times per week. No more than once in 24 hours. So if you gave yourself a shot one day and it didn't quite give you the results you were looking for and you're dosing yourself, you go up a little higher on the dose typically and see what happens, a day or 2 later. So
The
you,
length of that needle, what is it?
the length, 5/8 of an inch.
That's fine.
Yeah, so it's called BD Ultrafine, and it's 5/8 of an inch, and it's 31 gauge. It's the smallest insulin needle. All pharmacies carry it. So what you want to do is you're going to inject anywhere along the side. You hold the needle like a dart, okay? And of course you've washed your hands before you prepare any of the stuff. Alcohol the area that you're going to inject, and it's a straight poke. I tell patients it's a dart-like motion, okay, that leads to scar tissue.
So when you
So-
say put pressure, you mean right on the site?
Right on the site, couple fingers, or just harness the penis like this. Very, very important for 5 minutes. And if you're on blood thinners and your urologist is okay with you going on it, maybe you might need pressure a little bit longer. So over here for you guys, it's just a quick 1, 2, 3, poke, inject, take it out, and pressure, okay? So, and 3 days a week. I do find that most patients are able to, I don't exactly know the exact statistics, but most patients are able to get off of the medication, at least by 18 months or so. Some stay on it permanently. Others might get a penile prosthesis. Implantable penile prosthesis, if you fail these and your urologist has struggled with your dosages and your compound types, and the key to having success is starting you on Bimix, okay? Bimix injectable, not Trimix. So it comes from a compounding pharmacy. It's called Bimix or Trimix. We always start with Bimix because it seems to be very effective and it doesn't give the patients the pain that alprostadil and that other third ingredient in Trimix that would give. But it has to come from a compounding pharmacy, and you're going to have to work with your staff in Ottawa. I'm not really sure what kind of compounds exist, but if you can, Bimix is what we start with. We have, like I said, 89% success rate of guys that have been sexually active. When they come back, some of them, 22% or so, I've got to change them to Trimix because the Bimix wasn't that effective. So papaverin is the ingredient, phentolamine is the other ingredient, okay? So the pharmacist mixes them up and it's called Bimix.
But you start with Bimix.
What's that?
You always start with Bimix.
I always start with Bimix because even in the patients that you think are going to be okay with Trimix, a lot of them are fine with the Bimix. So I don't feel that you have to put that third ingredient in. The third ingredient, the Trimix, are usually the injectable that the patient circumstances would be a patient who's getting up in age, who had maybe some pre-existing erectile dysfunction, who might be on several blood pressure medicines or have a lot of what we call comorbidities. But even so, I've had some patients that present in that picture and they are fine on Bimix. And I want to prevent a prolonged erection. I don't want to put the patients all on Trimix. Dr. Menon thought that'd be a good idea when we first started doing this. We were getting a lot of guys coming through the clinic with erections that weren't going down. That was an emergency. We had to get that down, soon. So then we went, well, that's not effective for our penile rehab. Let's go to Bimix. We went to full-strength Bimix. That was a problem. We had to go back to half-strength Bimix. Now I'm back at full-strength Bimix, patient-specific. And so I work between a full-strength and a half-strength Bimix.
The Trimix, that include the third ingredient was in the injectable?
The Muse, yeah. So that Muse alprostadil, it's known as alprostadil, the generic, which you guys might be familiar with Edex. I don't know if you have Edex in Ontario. Have you heard of Edex? I don't know if they sell it here, or Caverject. But there's injectables that come from the pharmacies. That's the same thing as alprostadil, which is Muse, which is what the pharmacy will take as a third ingredient to add into the Bimix to make it more potent. But with that, you can get more penile pain.
Yes. Does the success of the injections depend on the nerve sparing technique, or how much
No, the beauty, good question. So what if nerve sparing technique has been an issue? It works very well with or without the nerves, as does the vacuum pump. The only medication that really has to rely on the nerves would be the oral medications. So, you know, you have choices, the vacuum, the muse, the injections.
Infection with the injections?
Infection?
Could there be infection with the injections?
You know, only if you reuse the needles or you're careless and you know, you're not keeping your supplies clean. But what's really imperative is that not only are you washing your hands, you don't reuse needles, and the compound, you know, you want to make sure that you keep it in a clean area and you swab it with alcohol on the rubber stopper before you inject it. I've never had a patient that had an infection. I had a couple patients who reacted and they've got some blisters, okay, and there's some other phenomenons that were quite, you know, not really sure what it was, but we took patients off, but no infection. Any other questions about the injections?
But if you're doing injections, are you still recommending that you do this oxygenation and stretching?
It depends on the patient's period of time that they're rehabilitating. I don't know how to get rid of this thing. I'm sorry. Hit something?
Yeah.
Oh, maybe it's froze.
Hit escape.
Oh, escape? Thank you. What you choose to do depends on your treatment, how long ago your treatment was, what you can afford, what you would prefer. I guess what your urology doctor, urology team supports, because you know you can run into a little bit of political issues when you get new ideas and you go to your doctor and you say, hey, what about this? You might get something frowned upon, and you know, I mean, that's the real world. I've seen it. It happens.
Yeah, I understand that, but I'm asking, you know, from your
Do you have to do other
your
things?
significant experience,
Mhm.
you're recommending using orals there
For select
for
patients.
oxygenation.
Yeah, that would be for extremely young patients, so under the age of 50.
Under the age of
Unless a patient said, I want to try the orals to make sure that I don't have to go to the injections. Because right away, like in the first 4 months, we usually just put them on the injections and the vacuum pump right now.
So you do that.
Yeah, we wait until they tell us that they're getting more spontaneous erections to put them on the orals. Because in our mindset, we're thinking, well, we're rehabilitating with the penile length, we're using the vacuum pump, patient's on injections, he's satisfied with sexual function.
So you're using the vacuum pump and injection.
Yes, yes. So the vacuum pump and the injections. And every patient that walks out of our door, if they were sexually active before surgery or they had erectile dysfunction beforehand and they were interested in becoming sexually active again, I pretty much get them on injections at that visit to teach them. I mean, granted, as long as they're in a mental ready state and their pathology report was favorable and they're mentally ready. In some cases, I wait and I have them come back and see me in a couple weeks. So it's patient specific. Any other questions on the injections? Yes.
Actually, I didn't want to ask about injections. I wanted to ask something that you haven't dealt with at all here, and that is pain associated with orgasm.
Okay, or orgasmic pain, yeah. That is a problem for some men. 10% of men after their prostatectomies may have, orgasmic pain. And it's a phenomenon in itself, and some urologists may prescribe some different medications to assist with it, but if you do have it, it may get better or it may stay. I mean, it's one of those things, that you may have to deal with it, orgasmic pain. I've had some patients, and we have considered giving patients drugs called Neurontin that help with neuralgias. Its generic name is Neurontin. Do you remember the generic gabapentin? Gabapentin, yeah. Yeah, that gabapentin is like a for nerve pain type of thing. And I think they might have, but I could be wrong, but like old antidepressant medications might be effective too in treating that. But it's something that may potentially get better after a period of time. I've never really had a patient that complained about it long term. Like I don't think I've ever seen a patient come back to say that they've had it, that it's been permanent. So
I've had it for 8 years.
okay, so I would definitely look into medication support to help that.
Well, I should be getting referred to a urologist, I should.
Yeah, a urologist that deals with sexual function, like it sounds like Dr. Bella would be
Yeah.
one of the ones to maybe get her,
How do you
Yeah.
spell that, Doctor?
Bella?
B-E-double-L-A.
Bella, yeah.
What age can you be before any of these are effective, like if you're in your 85s?
Yeah, oh, age is not
No barrier.
important at all.
Okay.
No, as is sexual activity, no barrier. As long as patients are heart healthy, we allow them to continue using any of these products that they want. So, we move on to, yeah.
Moving on from injections to venous leaks,
Yes.
what possibilities are there?
You have to see a urologist that specializes in that area because there's certain Doppler, arteriograms, ultrasounds that can be done to diagnose it. It first has to be diagnosed because it could be an assumption that that's what it is and it's not. So there are studies that exist, testing, diagnostic tests that specific urologists that deal with sexual function would do. But if that's the presumption, what you would do to treat that would, be something complicated like surgery, like a grafting kind of procedure. But what's the most simple thing would be a cock ring or a tension band, But it would be permanent because once you have the inability to maintain an erection, and you've been treated, it's unlikely that you're going to be able to reverse that. Because penile rehabilitation, the whole thought is if you don't treat it and target it soon, you'll get into a state where you could end up with venous flow problems. And you can't reverse the penile damage that has been done once the prostate's been removed. And that's why we have all these products that are targeting oxygenation to the penis to help protect it, and the muscle and the length. And
So that problem is due to the lack of oxygen or venous?
not always could be due to several different factors. Not necessarily, you can have a venous flow problem without even having treatment or surgery. It could be due to radiation, it could be due to aging, and I'm not that experienced with that specific topic, but what I would do as a nurse to treat it is we would put patients with different rings, sometimes doubling up on rings and so forth.
I have a question that maybe people in the room who experience it are better to answer, but it sounds like it's a long wait to see this Dr. Bella. Should your the urologist, the surgeon, who, when you see, 3 months after the surgery, should you be able to talk about all these things with them, and should they be prescribing some of
What
this?
you want to do is get a little, I can only say that definitely discuss it with your doctor. If you're not happy, get another doctor to discuss it with. Primary care doctors, general physicians, they have the means and the knowledge to get you your erectile dysfunction medications. All they need, all you need is a prescription. I had this discussion with a brother of mine. He lives in Peterborough, and he's a family physician in Peterborough. And I asked him, I says, well, when we're talking about all these treatments, he will write in his office, not a lot of them, but they're aware of the compounding pharmacies, and he'll get some select patients on their penile injections, and it's very common practice within a family practice. So if you're not happy with the urologist, try to target somebody else, a family doctor or somebody, because they're aware of it, they know about it. And if they don't, they might know somebody else that will, and so keep looking for it. Keep seeking, And urology-wise, maybe come with 2 or 3 burning things that you want to discuss, and make sure that you get answers before you leave. So Cure Magazine is a good resource for anybody that wants updates on cancer, that talks about any type of cancer. In September, they have features on prostate cancer and so forth. But all you have to do is go to their website, curetoday.com, sign up. It's a free subscription, and it's nice. So the research indicates that the best outcome may be combination therapy. So like I said, you picking what you want to do according to what your preference is, what side effects you've had, trial and error. It is a trial and error period. And I always tell our patients when I put them through this class, trial and error. Don't expect results overnight. It's going to take some time, some patience, some communication with your partner, improvisation, okay? Sometimes we like to go back to what we're used to, but sometimes it's looking at things a little bit differently. Being optimistic. Very important to be optimistic in your recovery period. I can't tell you how more often I see negative patients that really has an impact on their whole experience from surgery all the way post-operative. So if you have a good attitude, that's going to help you and take you places. And, you know, but keep seeking the information that you need. And that's it. Before we stop, I do want to answer a few more questions, okay? Because I think there's some more questions that need to be answered before we actually complete. Yes, at the back?
I'm taking Eligard, and I took Lupron, and I watched my erection bodies, or the corpus, atrophy in 2 months.
Right.
So this is all academic.
Right. Well,
For me.
Right, no, exactly. The Eligard or any hormonal treatment for advanced disease or disease that potentially has spread, or if you're getting it in combination with radiation therapy, it's going to definitely plummet your sex drive potentially because it's taking away testosterone sources in your body. You can still pursue penile rehabilitation if you're on hormones. But like I said, because that's separate from the Eligard and the Lupron and any of those treatments, you're doing two different things, trying to achieve two different things. You could still rehabilitate if you're interested in doing that. It's not going to hurt. You know, the hormone's doing one thing, these products are helping in another area. So it's not going to be, it's still going to be effective. But if it's been a 2-year period or longer, rehabilitation, I kind of throw that out the window. I'll just say, let's treat the erectile dysfunction. What do you want to use? Let's treat it. Let's see what we could do and use it permanently, and then potentially maybe gear that patient into thinking about an implantable prosthesis with an experienced urologist. That, you know, could be a viable option that patients would be happy with. Yeah, but good question. I forgot to bring up the hormonal therapy, but you know, it definitely can decrease your sex drive. I do have patients on injections who are on hormones at their request. Yeah. Yes?
It was a terrific slideshow. You explained at the beginning you were going to skip over parts so that you get to the erectile dysfunction section. Is it possible to get that slideshow in electronic version or printed?
Yeah, I can email it to these guys here. Yeah, the full thing. Yeah, time limited me to do the whole 2 hour just because a lot of times when I'm doing this for my patients that I know, I've had them do a lot of homework ahead of time. So they're tuned to what I'm going to talk about, so it's a little familiar. So I give them a taste of it. So, you know, I think that a lot of our questions kind of slowed us down a little bit. But, you know, and I know that the sexual function part of it is usually what's, you know, in most patients' mind. Continence is still something that I know that men deal with, and ongoing incontinence. If ongoing incontinence is a problem, you should look into surgical procedures with experienced urologists who do urethral slings, okay, or artificial sphincters, because it depends on how much incontinence patients have. Those are exceptional treatments for patients who are needing to use pads or have continued leakage that, you know, alters their quality of life. So that's another important part of my routine lecture that I give.
So, do you think, would you guys be able to circulate the slideshow by email?
Or maybe you could put it on the website. Your
Yeah,
website.
this is being taped. This is being taped, and actually Joseph asked me if I would ask Andrea to give us the tape or the slideshow so that we will have
We
that.
already have agreement. She will send it to me.
I'm going to send the slides to him.
Okay.
Yep.
Yeah.
Yeah, we've already
Okay.
looked at it.
Good.
He's way ahead of you, Bill. Yes.
Andrea, you directed most of your talk towards radical prostatectomies and prostatectomies.
Right.
How much different is the high dosage radiation brachytherapy and
I won't go there. Just it's only because it's not really my expertise. My expertise is all surgical.
Right.
But
Okay,
you
that's
know,
why you directed it towards.
exactly. And you know, the radiation oncology aspect of things, they're very similar results in terms of outcomes. Okay, brachytherapy, they all have their own place. Okay, and so you know, I see patients that might have had radiation and they want a salvage prostatectomy, and I've had patients that have had their prostatectomy and they now need radiation. I've also had some patients that had brachytherapy. So there's so many factors that are considered too, in size of your prostate gland, what specialists you see, because I don't know if you noticed, but if you see a surgeon, they're going to recommend surgery. If you see a radiation oncology, they usually recommend radiation, and so forth. So that's why I don't touch on that area. It's not my expertise. I don't have the statistical data in my mind. I don't keep track of it. I'm not up recent to the conferences of what's going on and what's happening in that world. So.
Well, my question was directed towards the remedies that you talked about. Would they apply to people who need radiation?
Yes. The remedies, let me clarify, and thank you for saying that. The remedies that I've talked about will be applicable to any forms of therapy that you've had to treat your prostate cancer. Okay? So thanks.
When you talk about the results and so forth, and for instance with the vacuum pump, some of the men didn't like it or something or other. Is there anything you have that's sort of more scientifically based on anecdotal evidence? And there's nothing that even relates to the partner's responses? Because it seems to be all men talking.
There's what?
It seems to be always the men talking to you.
The women too. I mean, usually, well, it depends. I mean, I'll see them based on whatever they want, convenience, time of day. Often I'll see patients in the clinic and their spouse or partner's not with them because they have to work. The ones that they are really struggling with it, the both of them, they'll show up together. So there's mutual
Even then,
feedback.
it's all anecdotal, really.
Exactly.
No
So I don't have, yes, and there, you won't find that in this field, that there's nothing research-based that I know of that exists. So a lot of it is based on experience, anecdotal evidence.
Why is there nothing, I don't know, studies?
You need money in studies, and
You get money
people
from
haven't,
outsourced stuff.
well, it's easier said than done.
You said that people in radiation would advise you to do radiation, or if your surgeon would say do surgery. My surgeon advised me, he said, this is what happens with radiation. And he said, there's no doubt in his mind they are good. But the choice is mine if I want to do radiation, if I want to do radical prostatectomy.
Correct.
He said that if you do radiation, and later on you want to do prostatectomy,
Right.
radical prostatectomy, you can't.
It's a very difficult procedure, and that's because the radiation damages and scars the tissue, and it's difficult to differentiate healthy tissue from cancerous tissue.
Yeah,
So it's difficult to do.
He advised me and told me about that.
Yeah.
However, I mentioned something to our group that helps me, and apparently nobody seemed to try it. So I'm not going to mention it to you because it's on a more professional level. I told Bill what helped me to get an erection. And apparently none of the guys, if only one person tried it, it would have been worth mentioning it to you, but nobody seemed to try it, so I'm not going to mention it.
That's not fair.
Now you've got us interested.
Yeah. I take one ibuprofen, 400 milligram in the morning after breakfast, and one at night, and it helps me. To be very candid, in the middle of the night, I am awake, I am roused with a very, very hard erection. And ibuprofen.
Is your girlfriend winning?
Ibuprofen. It may not work for some other guys, but if somebody would only try and see.
Whatever works for you.
There you go.
I've got to go, guys, but I thank you very much for listening and talking, but I guess we should just wrap it up.
Yeah, we will wrap it up now. I think from the interest in all the questions, this could probably go on until midnight. But Andrea does have to leave and get back to her family and her job and that. I do think that this event here shows that we have a need for a program such as Andrea has in Detroit and Windsor and some of the surrounding hospitals. So perhaps if there are any urological nurses local here, and I do know of at least one, please, make contact with the urologist. I know that the urologist I'm thinking of is the chief of urology of the Ottawa Hospital, and he has some pull. So let's see if we can get something done. On that note, I want to thank Andrea so much. I've dealt with Dr. Bella for a number of years. I've learned a lot this afternoon, and I think that, God bless you. John Arnold and I wanted you to leave Ottawa thinking of us as a really sweet group of guys. So a small cadeau of local honey.
Ooh, really?
Really, for you.
Oh, thank you. Thank you so
It's
much.
from a local,
Wonderful.
yeah, and God, I really hope that we're able to
Wow.
see you
Thank
again.
you. Yeah, I hope to be back.
Yeah.
I mean, it's a beautiful city. I haven't